Thank you very much for the kind introduction, and I'm very glad that all of you came out this morning. So I am going to talk about poverty and disease. And interestingly enough, the relationship between poverty and infectious diseases goes all the way back to what most people consider to be the first epidemiological study that was ever conducted. So this is Snow's 1855 study of cholera in central London. So this is a map here on the left of the Golden Square neighborhood of central London. Each dot, if you can see them in the back, is a known cholera case. The X's, which you probably can't see, there's one here, there's one that's buried there, are water wells. And so Snow very famously found this association between this water well here and where all of the cholera cases were occurring. And the story goes that he convinced the public health authorities to go out and smash the handle off of the water well, and the cholera cases went away. About 50 years later, in 1898, another John Booth, published the first high-resolution map of income from anywhere in the world. So block by block in London, Booth quantified the income of the individuals living in the households on those blocks. And it's a little bit hard to see, but basically the scale goes from gold to black, red to blue and purple, increasingly impoverished. And I've put an X here on the map where that water well was that was contaminated with cholera in the Golden Square neighborhood in London. And as you go towards this water well, it moves from gold to blue to purple to black, increasingly impoverished. So all the way back to the first study that was ever conducted of the association between humans and the diseases that infect them, we see a relationship between poverty and disease. And this has been borne out in the next 150 years of scientific research on infectious diseases. So essentially, anywhere where anyone has looked, there is a positive relationship between poverty and disease. This is true for chronic diseases, for non-infectious diseases, and for all infectious diseases where anyone has looked. The chart that we're looking at here was modified from a paper in 1999 where they were trying to understand what some of the drivers may be between this association of poverty and disease. So what we're looking at is this is income inequality. So as income inequality increases, what happens in these impoverished communities? Well, you see, one, their life expectancy goes down. And this arrow pointing directly from this box to this box means that it goes down as a direct effect of income inequality. Presumably, this is because of poor environmental quality in the places where individuals in more impoverished neighborhoods are living. But there's also an indirect effect mediated by primary care, which also decreases life expectancy. So you have reduced access to health care, which reduces your life expectancy, reduces your overall quality of life. And this has become an area of research both in economics, behavioral sciences, and infectious diseases, where they talk about these poverty traps. You have individuals that live in impoverished neighborhoods. They have lower access to health care. Neighborhoods are often of lower environmental quality, which decreases their life expectancy, increases their disease burden, and then decreases their economic prospects. So you have this feedback loop between poverty and disease that essentially traps individuals in these impoverished neighborhoods and in these impoverished parts of the income distribution. The first study that I want to talk about is work that I've done in collaboration with the City of El Paso Health Department. And this was to try to understand the role of poverty and influenza in El Paso County, Texas. So what we're looking at here is reports of flu-positive cases to the health department in El Paso from October 2013 through April 2014. And what you can see is that this looks like a normal flu season if you've ever looked at normal flu seasons before. You have relatively few cases early in the season. It takes off with a peak in January or February, and then it tails off again. And one of the reasons we're so interested in this particular study is because there's increasing efforts to try to predict these time series, very much the way that people try to predict the weather. And the argument that the research group that I work with tries to make is that we can't actually predict this time series if we don't understand the underlying drivers of disease, one of those being poverty. And so I'll just play, hopefully, a quick video of the flu season at the zip code level. And what I want you to notice, so each of these blocks is a zip code. They'll light up in red as increasing number of flu cases are reported. What you'll notice is that there's lots of red flashing on. That red just went from red to white, back to white again, which means that you're getting a lot of flu reports on one week, and then a week without any flu reports, and a lot of flu reports on another week, and a week without flu reports. So as you drill down into the local level, and anyone that works on infectious diseases understands this very well, as you drill down onto the local level, you don't end up with a smooth curve of infections. It's much more noisy. And it turns out that it's more complicated than that if we look at the role of poverty in how these new cases are being generated. So these are, again, the zip codes in El Paso County, Texas. And these zip codes range between 0 and 65% of the zip code living below the national poverty line. Okay? And so the lighter blues are zip codes with fewer individuals below the poverty line. The darker zip codes are individuals with more people, or zip codes with more people below the poverty line. And when we look at how flu cases occur in these zip codes, what we see is that the poor zip codes tend to be much more correlated with each other with respect to flu cases than they are with the richer zip codes. Okay? And this is not something that anyone has discovered before about infectious diseases as they relate to poverty. So as I mentioned, it's well known, and we see this here, that you have more flu cases in increasingly impoverished zip codes. So you have more flu cases down here along the Rio Grande and the Mexico border than you do further away from the border. But these zip codes down here are more in sync with each other with respect to their flu cases arriving than these zip codes are, these richer zip codes are with each other. And one of the ways that we can try to visualize this is we can place a dot in the center of each zip code, and we can color code the dots based on those zip codes that are most in sync with each other. So the red dots are more in sync with each other than the blue dots are. And I'm just drawing lines between them to represent the correlation. So the darker the line, the more highly correlated those zip codes are with each other. And what you'll see is this band of red largely along the Rio Grande and the Mexico border where those most impoverished zip codes were, and then a second band of blue further away from the border. And we can look at this a little bit more quantitatively. So we can ask, is it just geographic proximity that explains this synchrony? And the answer is no, and you could probably tell that just from looking at the plot. So you have zip codes that are neighboring each other that are very much out of sync with respect to flu dynamics. So what I've done is just come up, so in terms of a map, you have 2 dimensions, latitude and longitude. You can collapse those down to a single dimension. You lose a little bit of information, but the points together here on this y-axis, which is a one-dimensional description of distance, these 2 points are closer together to each other than this point and this point are. And you notice how the red and blue points are all mixed up together, which means geography does not separate the red and blue points from each other. What does separate the red and blue points from each other is poverty, so this being fewer people below poverty, this being more people in poverty, and vaccination, so this being higher vaccination coverage, lower vaccination coverage for influenza. And you'll notice that the blues are flipped here. So the richer zip codes have higher vaccination coverage for influenza than do the poorer zip codes. So we're seeing here an effect of access to health care. So these data, again, are largely from before the Affordable Care Act came into play. And so many insurance companies were not covering influenza vaccines, and it was relatively difficult for individuals to get access to those freely available vaccines that are provided by the state. We did a similar study in the Dallas-Fort Worth area, and we found many of the same conclusions that we did in El Paso. Namely, that there's a positive association between poverty and influenza. The poorer zip codes are more in sync with each other than are the richer zip codes. But we are able to come up with another conclusion as a result of this study that I think has even more profound consequences for our understanding of the role of poverty, disease, and in this case, public health. So what we're looking at is now we've moved north and east a bit to the Dallas-Fort Worth area. There are 5 counties that we include in the study. So here's Dallas, here's Fort Worth, and then the surrounding counties. And again, I've just color-coded the zip codes based on the proportion of the population living below the poverty line, so ranging between 0% and 50%. Here's the result that I have alluded to a couple of times. These are the number of inpatient hospitalizations due to influenza per 1,000 people. in zip codes going from 0% below poverty to 50% in poverty, and you see that there's a positive relationship, more hospitalizations in poor zip codes. Now this is a rate, so it controls for differences in the number of people that live there, but you actually have more people living in the more impoverished zip codes. So you have a higher rate of hospitalization, you also have a higher absolute number of hospitalizations because you have more people living there. So what the state of Texas asked us to do is to find out whether we could predict these inpatient hospitalizations. So hospitalization data comes into the state of Texas about 3 to 4 months after it happens. But hospitalizations due to influenza are very expensive. So the hospitals in Texas, what they bill to the insurance companies for influenza hospitalizations works out to about 1% of their GDP per year. So it's a lot of money for influenza hospitalizations. They also make very complicated and complex staffing decisions related to triaging these individuals when they come through the doors. So they very much care about these hospitalizations. So what we're going to try to do is take data that are available on a weekly basis to the state of Texas. So they get weekly provider reports from primary health care providers. They fax in or they email in reports on flu cases. Google provides an estimate of the number of flu cases based on what people are searching for on Google. So if you're searching for antivirals or you're searching for cough and fever, they provide an estimate. We also get data from emergency departments. So the electronic medical records, when you come in and the physician or nurse writes down the chief complaint, when you walk in the emergency department, we can see those data basically on a daily basis now. And we can try to use those to predict these inpatient hospitalizations. What we find for these inpatient hospitalizations, again, as I mentioned, is the same thing we found in El Paso. So these are the richest 25% down to the poorest 25% of zip codes. And these are the correlations, so basically a measure of the synchrony between those zip codes, between the poorest zip codes with the poorest zip codes, the richest zip codes with the richest zip codes. And what you see are these boxes creeping upwards. So 1 means perfect correlation, 0 means no relationship whatsoever, creeping upwards as we go from the richer to the poorer zip codes. And in fact, this difference between the correlations of the poor zip codes and all the others is statistically significant by just about every test you could imagine throwing at it. Okay? Now, this is kind of an interesting finding, right? So if you think about this map here, these are very much urban counties, Dallas and Fort Worth, and you see that the darker blue is clustered in the center. So you have individuals living in the urban cores in these impoverished zip codes. But you also have comparatively more rural counties, and again, individuals living in rural areas that are also well below the poverty line. So it's not the case that there's some urban poor differentiation. There's something about living in poor zip codes that transcends differences between urban areas and rural areas, that transcends differences in population density. So as I mentioned, we're going to try to predict these data up here. So these are the inpatient hospitalizations from 2007 to 2012, using data from primary health care providers, the Influenza-like Illness Network, data from emergency departments, what's called BioSense 2.0, and then the influenza-like illness data that comes from Google based on search queries. We're going to use these to construct a predictive model that says, okay, if I see these cases or these reports on this week just before 2010, how many hospitalizations do I think are going to occur next week? How many hospitalizations do I think are going to occur in 2 weeks, 3 weeks, 4 weeks, and so on? And it turns out for the richest zip codes, we can do a pretty impressive job of predicting this. So going from 2007 to 2012, the data are the black circles here. So these are the number of individuals that actually walked in, were admitted as inpatients in the hospital, and had laboratory-confirmed influenza. And the blue curve is our 2-week ahead prediction of the number of cases. So for those of you that are used to thinking about this kind of analysis, this is impressive for a couple of reasons. One, the counts on the y-axis are very small. So even at the peak of flu season, we're only seeing 20 cases in a week reported in the richest zip codes in the Dallas-Fort Worth area. Okay? So this is a very sparse time series is the word that we would use, and we're doing a very good job at predicting the time course of these. However, the same is not true in the poorest 25% of zip codes. So again, the same type of plot where we have the circles representing the cases that are actually reported from 2007 to 2012, and then our fit or our 2-week ahead estimate in red. Now you notice a couple of things. One, the y-axis is higher, right? So it goes all the way up to 35 here. So we're seeing 40 cases reported on a given week. So we actually have more cases being reported, as I mentioned, in these poor zip codes. But you'll see that the red line is substantially further away from the gray dots in this case than it was for the richer zip codes. In fact, you'll notice here that we predict a very light flu season in 2010, but in fact it was a very big flu season. We underestimate by about a factor of 2. Towards the end of the 2009, there's this big red peak, and there's actually no dots below the red peak. The dots are way down here, so we substantially overestimate the number of cases that are coming in. Now this is interesting because there are more cases reported, and these zip codes are more in sync with each other. So from a statistical perspective, we should actually be able to do better at predicting this time series than predicting the other time series. This is a much harder time series to predict, all else equal, than this one. Okay? So what does this tell us? Well, this tells us that what we know about poverty, that it reduces access to health care, also has a negative effect on our public health awareness, because we have impaired ability to predict cases in these poorest zip codes. Why is that? Well, it's because we're using data from healthcare providers to try to predict inpatient hospitalizations, and these individuals are not able to go to the healthcare providers. In fact, one of the more surprising results, we actually predicted a priori ahead of time that the emergency department data would be very useful at predicting these inpatient hospitalizations in the poorest zip codes, and that turns out not to be the case. The emergency department data is no more useful in the poorest zip codes than in the richest zip codes. So one of the potential implications is that these individuals are not even using emergency departments as their primary healthcare provider. They're just being admitted directly as inpatients into the hospitals. And this might seem surprising. There are a fair percentage of inpatient hospitalizations that never see the emergency department. They go directly into the hospital. But when you think about it, even with my insurance through the Santa Fe Institute, I have to pay out $100 every time I walk through the door of the emergency department. If I didn't have insurance, I don't even want to guess what they would try to charge me if I walked through the door of the emergency department. So maybe when we put that in the context, it's not so surprising that these individuals are not able to go to the emergency department. So now we have not only the fact that we have higher disease burden in these populations, but we also have an impaired ability to make public health decisions in the communities that need those decisions to be made as accurately as possible. So again, we found that this relationship, as I started with, between primary care reducing life expectancy because individuals in poor zip codes have reduced access, also has a key public health consequence. And this relationship between income inequality directly on life expectancy plays out in influenza as well. So by and large, the majority of influenza hospitalizations in Texas are a result of either being elderly and having pneumonia or being a child and having asthma. Okay, so if you have asthma, you get infected with influenza, and if you don't have the proper medication you need, you're going to end up in the hospital as a result of exacerbated asthma symptoms. Okay, so that's what most of these hospitalizations are actually being driven by. So I want to switch and just end on a discussion of the Ebola outbreak in West Africa. So as I'm sure many of you read, there was a lot of interest in why this Ebola outbreak was so large. Right? So we've been having Ebola outbreaks since the 1970s. We've been having Ebola outbreaks in impoverished parts of the world since the 1970s, but we've never seen large-scale Ebola outbreaks like we did in West Africa. So one of the predictions was that there's more connectivity in West Africa now. There's increasing road networks that move amongst all these capital cities. And that's certainly different now than it was in the 1970s. Okay? One thought was that perhaps the virus evolved some way to be able to transmit a little bit better from person to person. Again, there's not good evidence in favor of that, but it's still plausible. However, what we believe was almost entirely overlooked was that the healthcare systems in these three countries, Liberia, Sierra Leone, and Guinea, are almost entirely non-existent. And this was true even before the Ebola outbreak. Okay? So I read about this a couple of times in the paper, that these three countries have very few doctors, very few nurses, very few hospital beds, but I hadn't actually seen any numbers associated with that. And it turns out one of the things that we have very good data on at the global scale is healthcare. So the World Bank and a number of other agencies maintain very detailed records from different nations on their healthcare availability. So I pulled those data and did a very simple analysis. So what we're looking at here are the number of physicians per 1,000 citizens of the country as a function of healthcare expenditure per person in US dollars. So you're spending more, you have more physicians. These are both on a log scale, which means that they're changing much more rapidly than they would change if it was a linear scale. So you'll see it goes from 7 to 29 to 115 all the way up to $7,000 per person, 0.02 all the way to 20. But I've back transformed them to be the actual numbers. So the scales are changing very rapidly, but these are the real numbers. So 0.07 physicians per 1,000, spending $7,000 per person. Each country is represented as a dot on this plot here. Okay? So a couple of things to take away. One, this is us way out here. We spend more per person than any other country in the world. But as you'll see on the next two plots as well, we actually have lower per capita rates of all available health care than we should have given how much we're spending, which is not a surprise, I think, to anyone. Liberia, Sierra Leone, and Guinea, as I mentioned, are among the worst in the world with respect to all three metrics that I'm going to show you, but this is physicians per 1,000. They have, on average, about 1 physician per 20,000 people before the Ebola outbreak. So that works out to about 5 doctors in Santa Fe before the Ebola outbreak. All right. As a comparison, Nigeria, which is still well below the world average, in fact, it's a factor of 10 below the world average, has about a factor of 5 times as many physicians per 1,000 as Liberia, Sierra Leone, and Guinea. Okay. Now, I put Nigeria up there because Nigeria had Ebola cases during the last outbreak, and they were able to prevent a widespread epidemic from occurring. And now, how are they able to do this? Well, they were able to do it the same way we did in the United States, which is that you isolate the individuals that are sick, you go and find their close contacts and you monitor them, and if they become sick, you isolate them. So public health is how you stop Ebola outbreaks. That's how they've stopped it since the 1970s. And they were unable to do it in these 3 countries because they had no public health system. The same is true for hospital beds. Again, they have about 3 hospital beds per 1,000 people before the outbreak occurred. And the same is true for nurses and community healthcare workers. Again, about 3 hospital beds per 1,000 people. Now, I did a final calculation, which was to try to ask how much money would it have cost to bring all 3 of these countries up to the Nigeria levels. Okay, so let's just assume that if we have the same per capita rate of physicians, hospital beds, and nurses as Nigeria in each of those 3 countries, we could have stopped this Ebola outbreak from becoming widespread. The answer is somewhere between 15% and 50% of what we spent on advertising in the midterm election that was going on at the same time as this occurred. Now, why 15 to 50%? Well, you'll notice that there's a relationship between spending and infrastructure, and that all 3 of these countries are falling below this dotted line, which means they're not as good at translating spending into infrastructure as some of the other countries in the world are. So if you take full account of this loss in translating spending in infrastructure, it's 50%. If you assume that they're not going to waste any of the money, it's 15%. So the real number is probably somewhere like 30 to 40%. But we're talking about somewhere around $50 to $200 million, which pales in comparison to what we spent on this outbreak in these 3 countries, and absolutely pales in comparison to what the economic costs of the Ebola outbreak were globally. The last thing I want to mention about the Ebola outbreak, and it doesn't really have anything to do with poverty directly, is the importance of basic science research on our understanding of these diseases. So there was a call on Twitter to tweet about your favorite basic science discovery in the last 100 years. And certainly we should have something about going to the moon or the microwave or Tang, other things associated with the moon, but probably not Ebola. But the thought experiment that I wanted people to do for themselves was, and maybe we can do this now very quickly, when the individual from Liberia walked off the plane in Dallas and was sick with Ebola and went to the hospital and exposed people and went home and exposed everybody living in the apartment building with him, we knew without a doubt, as a result of basic science research on a neglected tropical disease, that Ebola was not transmissible until that patient showed symptoms. We still panicked in the United States, had a huge economic effect. Imagine if we hadn't known that. Okay, I don't think it's unreasonable to believe that we might not have airlines to fly on anymore, because they might have all gone under because people stopped flying on airplanes because of the fear associated with catching Ebola if we hadn't known that. Okay? So it's very difficult to predict 10, 15 years into the future the types of questions we're going to have to ask and answer, which is why we do basic science research, which is why we try to make the types of creative discoveries that we do up the hill at the Santa Fe Institute, because we may not need them right now. It may not be obvious what the benefit of this is going to be today or tomorrow in 10 years. But in 15, 20, 30 years, we may be looking back and being very proud of ourselves that we invested a little bit of money in figuring out that Ebola wasn't transmissible before individuals showed symptoms. And this is the type of research that we're working on as it relates to infectious diseases at the Santa Fe Institute. We're trying to understand how the evolutionary relationship of pathogens, so these are the evolutionary relationships between the Ebola viruses in West Africa, interact with things like poverty, with global connectivity, with human behavior, to result in these time series that we very much care about from both a public health and an economic perspective. And I think you don't have to try very hard to imagine that if you don't have good models and individuals with deep expertise in all of these areas, from evolutionary biology to ecology, the behavioral, social sciences, economics, mathematics, statistics, computer science, you can never hope to integrate these in a meaningful way to actually affect a positive outcome on the diseases that we care about. So with that, I'd like to thank the collaborators that worked with me on the influenza work: James Scott, Ned Dimitrov, Roz Ego, and Lauren Ansel Myers. Lauren was my PhD advisor at the University of Texas. Alejandra and Fernando are my collaborators in El Paso. The National Institute of Health, the Santa Fe Institute, and the Omidio Group provided funding so that I could do the research that I discussed today. In particular, the National Institute of Health MIDAS Group, which stands for Models of Infectious Disease Agent Study, and the Omidio Group and the Santa Fe Institute, they allow us the flexibility so if there's an Ebola outbreak, we can drop everything we're doing and spend 6 months working on the Ebola outbreak. Spend 3 hours every week on the phone with decision makers in Washington, informing them of what our mathematical models are saying about the Ebola outbreak in West Africa, without having to worry about whether we're going to have a job to come back to, without necessarily having to worry about publishing or getting grants. There are very few agencies that provide this kind of funding, and in fact, the NIH MIDAS program is going away. It's in its last few years of existence. So without this kind of funding, we can't even do the types of research that we need to do during these ongoing Ebola outbreaks. And what I'll mention at the end, and I'm going to mention this because the New York Times didn't give the Santa Fe Institute the citation we deserved. So the CDC famously overestimated the number of cases in West Africa by a factor of 1,000. Okay? At the same time, the models that we were working on were only off by about 4%, 4 to 10% over the same time period. And Washington knew about those estimates because we were on the phone with them every day. The New York Times wrote a study about this. They thanked Yale, who was also involved. They didn't thank the Santa Fe Institute, even though we led the study. But this is, again, why having this type of funding is so critically important. All right, well, thank you all very much. It was a pleasure having you here.